So we've heard a lot already this morning about some of those social determinants that are important for addressing health disparities and getting more towards health equity. And so we're now going to hear about some folks doing some really important work on a couple of those areas, that being impacts of migration and gentrification. So we've heard a lot about the movement that's happening across the region and how that's impacting what's happening around HIV. And in particular, we're going to hear much more about how migration and gentrification is really impacting our communities. We see it on the streets, as it's been alluded to earlier this morning, around encampments. So we're going to hear about some of the work that folks are doing. So I'm just going to briefly introduce all of the speakers, and then they'll be coming up. So first, we're going to have representation from Contra Costa County, Obiel Leyva, who is a community education and testing manager, has been working in the field for a while, doing data to care, and really focusing on decreasing repeat STD cases. That will be followed up by CALPEP's Roger Jackson, who was a coordinator at CALPEP and has been working in the field for many, many years, including being an HIV test counselor, a case manager, and working around in the treatment area. That will be followed by Miko Thomas, who is a two-spirit activist, and I can't even read my own notes here. Veteran of the U.S. Navy, been working in the field for a very long time, and that will end the panel with Miguel Ibarra, who is a homeless health outreach program manager, has been working around treatment, linkage, retention, risk reduction counseling. So we're very fortunate to hear, again, this regional aspect around migration and gentrification. So first up, Obiel.
Okay, I feel special now. Great, thank you. Good morning, buenos dias. My name is Obiel Leyva, and yes, I've been working in the field of STD HIV prevention for about 25 years, since I was 2, right? And I work with Contra Costa County. I'm in the Contra Costa HIV/AIDS and STD program. One of the ways that we're different from other county programs is that we actually merged about 8 or 9 years ago. We merged the HIV/STD we merged the HIV/AIDS services with the STD program. And a lot of counties nowadays are actually going through that merge themselves, which is great. Let's see, so what about Contra Costa County? So part of this information, a lot of this information you've heard from other speakers, which is great, so I'm gonna cut my presentation short. So we are part of the Oakland TGA, as you've heard. Our population is about 1.1 million. We're about 800 square miles, so we're like a mid-sized county. When we talk about Contra Costa County, we have to talk about the 3 regions of the county. So when we say West County, for example, we're really talking about like the anchor cities are like Richmond, Pinole, San Pablo. Central County, we mean Concord, Walnut Creek, Martinez. And East County is Pittsburgh, Antioch areas. The county is very interesting because it can go from very like ultra urban to very like rural parts of the county. Particularly in East County, there's a lot of space, open space, a very rural area. We are considered sort of a bedroom community. So someone already mentioned, we're very politically conservative in Contra Costa. Also individually conservative, which is interesting because, in our testing program, a lot of folks, when they present to testing, we're supposed to target and reach high-risk individuals, right? And so a lot of folks, when they present themselves to us, they, present with a very low-risk profile, right, at the beginning. And so we use our client-centered testing skills to really bring out, the information from the client. And a lot of men do this. So for example, they start with, I only have sex with my girlfriend or my wife in this session, right? And about 15, 20 minutes later, after they've they build sort of trust with us, and we ask a lot of open-ended questions. Sure, they do have a girlfriend and a wife, but they also have 1 or 2 or maybe 10 male partners, right? So people are engaging in behaviors, but they're just not really talking about the behaviors. So we have 1 gay bar in our county. We have no bathhouses, no sex clubs, and as one of my heterosexual coworkers mentioned, no gentlemen's clubs either. So let's see. So what are the effects of migration and gentrification patterns that we're seeing in our county. So according to urbandisplacement.org, which is a great website, by the way, I recommend the website, ongoing gentrification is seen in Richmond, with advanced gentrification seen in Point Richmond and Hercules, and also in the Antioch and Pittsburgh Marina waterfront areas. And as Dr. Liu had mentioned before, and according to the Metropolitan Transportation Commission, we present migration in Contra Costa County is coming mainly from Alameda, San Francisco, and San Mateo counties, while migration out of the county in smaller numbers is going to the Central Valley and Sacramento, which again is where people see that they're more affordable housing areas. The effect of migration within the county is that when folks are displaced from West County, a lot of them are moving to East County. And so that really has effects on sort of long-term, sort of historical communities, for example, in Richmond, which has been traditionally an African-American community, but the migration and the displacement patterns are making it so that they're moving out of that area more to East County or out of county as well. Let's see, another thing that's really sort of moving migration is more affordable housing is being built in East County. And really the case in our county is, what we see is the closer you live to San Francisco, so i.e. West County, the more expensive it is to live there. So rent to purchase a home is higher in West County than it is in other parts of the county. Let's see. And then anecdotally, we've seen this in our case management program. We're seeing more and more new patients, new clients reporting that they're living in Central and East County. And currently the majority of our HHWA units are actually in West County and Central County. So I think what this migration pattern is also showing that the need for future HHWA units, we really need to build more and more in East County area as well. Let's see, these are the programs that we provide. The other thing that makes us a little bit different from other counties is that the majority of these services are actually provided in-house. So our, for example, medical case managers, the majority of them they're county workers, they work in our departments. The folks that do the testing and the outreach services, they are disease intervention technicians that, again, they're hired, they work in our departments or they're county employees. So we don't subcontract most of that work out, we do it in-house. We do subcontract some specialty services out, like transportation and food. We work with agencies to provide those services. And also, too, in the prevention program, we subcontract out. We work with the Rainbow Community Center. It's our LGBTQI center in Contra Costa. And what they do is they go out and outreach and they target MSMs and they bring them to our testing services. And also, as mentioned before, we contract with HEPAC. They provide our weekly needle exchange programs. We have positive health centers in the county. And again, these are county-run health centers. And they're in San Pablo, Martinez, Pittsburgh, in Brentwood, and they provide HIV medical care services to the majority of the clients that we provide case management services to. We also have 3 STD clinics that are, again, county-based, county-run, and these are evening clinics. So in our testing program, we really do a lot of referral and sort of warm handoffs to the STD clinics. A lot of the folks that come to test with us, it's like a lot of them first time they're testing for HIV, and when we ask about, have you been tested for other STDs, a lot of them, particularly among MSMs that we test, say no, they've never had an STD checkup. So we really make a connection to either our STD clinics or we have 6 Planned Parenthood clinics in our county that we work with. Let's see. And then, so the last thing I just wanted to sort of highlight about what we're doing to really reduce disparities is we started in our prevention program, we started data to care and PrEP education and navigation services. So what we're doing in our data to care program, we call it the Lineless program. So about a year ago, what we started doing, we started saying, well, we have these great, we have a mobile testing unit that, goes out and does testing. We test at agencies, right? But the model still, we're going to a place and we're waiting for people to come to us, right? How can we become more proactive, right, to reach people that are really, really high risk? And so what we're doing now is we're using surveillance data. So we're looking at individuals who have had at least one STD in the last 3 months, right? We're pulling all those individuals, and then we're sort of sorting them out by high-risk populations according to our prevention plan, which are MSMs, women of color, transgender individuals, and individuals that are HIV positive or co-infected with another STD. And when we're putting them on line lists, and the DITs, again, the testing counselors, they're working on this project. And what they do is we wrote out scripts that they follow, and they reach out to each and every one of those individuals and talk to them about, to make sure that they've gotten their treatment, that they understand how not to get a repeat STD, and that they understand risk reduction, and then about our testing and PrEP services. And then they make referrals during those calls and those contacts to our other services. So that's one way that we're sort of, instead of waiting for them to come to us, we're actually going to them, and we're in their ear. We're calling them, talking to them, meeting with them, sending them into our services. And and through that project, we've reached about 1,300 individuals in the last year. And the majority of those are people of color, MSMs of color, or women of color, and people living with HIV. Thank you.
Roger?
Good morning, I'm Roger Jackson, I'm from CALPEP. Say good morning. There we go. All right, okay. Now I understand that, some of us have these sultry voices, and so we just kind of lull everybody into this deep sleep, but it's okay. We're gonna do this. I wanna take a minute and indulge me if you please. I want you to think about the neighborhood you grew up in. Think about a young child growing up in a neighborhood. His grandmother's house was there. His mother lived in that same house. He grew up in that house. Imagine this kid going to the same school most of their lives in the same neighborhood, never really leaving that neighborhood much. Now, this very same person becomes a teenager. They may actually go off to college. It might not work out quite the way they planned it. Have a child, maybe get hooked on drugs, or maybe life just hits them really hard. This young adult, as they continue through their journey, their employment situation gets a little rough. So much so that they can't find a job. And the jobs that they can find, they won't pay for their basic essential needs. They have to choose between food in their bellies and a roof over their heads. Many of them end up in situations where they're in their cars because they can no longer afford to live in their homes. Now imagine this home that this person grew up in. Their mother grew up in that house. Their grandmother was in that house. And they lose this house because they cannot afford to pay the taxes, because their primary caregiver was shot a few years ago. And nobody has been able to really sustain that household, because their primary provider in that house has been in prison for several years because they committed a crime trying to feed the family. Now, mind you, they weren't literally feeding the family at the time. They were stealing something so that they could actually so they could sell it to pay for these basic necessities. Imagine this area being Oakland and watching the neighborhood you grew up in become unaffordable to you. Now, imagine you grew up in Oakland and you had the Panthers, you had this black mayor, you felt like somebody in this society, in this community. So you are determined to not leave this community that you feel like you helped to build. You've put your tax dollars into it when you had a job. You put your heart into it. Your friends are there. Your family's there. You lose your home. Where are you going to go? Don't want to go anyplace else. Oakland is my home. This is what many of our clients face. Not everyone who is homeless is strung out on drugs. Now, I'm a part of a very important, what I consider a very, very important agency, because we do a lot more than just HIV testing. I'll run down some of the things that we provide, just so you can be familiar with who we are and what we do. We've actually been in existence for about 34 years, 33 and a half. Our executive director is Ms. Gloria Lockett. Thank you. She's an ex-prostitute. And she says she doesn't mind me saying that because this is where she came from. She's an ex-prostitute who noticed or identified a need in the community. We've been doing this since the 80s. Originally, we went through the whole GRID thing, the gay-related immune disease, and this was all about gay men, and we went from GRID to, it's the gay men and the prostitutes. They're actually infecting all of these wholesome, good men who are going out there just to have a good time and going back to their wives and living their normal lives. And Ms. Lockett said, okay, look, hold up. All of this blame that you guys are this pointing the finger and stuff, this is ridiculous. And the fact that you're actually trying to blame working women, people who are trying to survive, people who are trying to make it, you're trying to blame HIV on them is absolutely absurd. So I'll tell you what, we're going to educate these women. And so she started an agency called CALPEP. Originally, she was also a part of Coyote. So CALPEP was started. We had an education component. We also had a testing component. So we would actually go and have what we have called outings. Now, outings were actually in hotels. We did this in San Francisco, Marin, and eventually we were doing it in Oakland. This was late 80s and rolling into the 90s. Now, in the outings, I don't have any pictures of the original outings. You guys will have to come to our 34th anniversary in December to actually see those. But this picture here, this is simply a picture of our outreach van actually going out doing testing. We were doing HIV testing at this particular time at one of the encampments here in the inner city. We provide testing. We provide linkage to care for positives. We provide PrEP referrals. We have a number of different drop-ins. Our future program, it's 13 to 24 youth. That operates on Mondays and Wednesdays. We also have our base program addressing the needs of our transgender community. That actually takes place on the Thursdays. We have a drop-in for MSMs, and that's also on Tuesdays and Fridays. So we actually have a number of different drop-ins. We provide case management. We provide PrEP referrals, linkage, and we also provide HIV and HCV testing. And eventually we'll get back into doing our medical screening. But I'm up here, and I want to show you a couple of pictures. Now, this is just something that we've discovered as we were out testing. In this picture, this is simply a Sutter Health in the corner over there. But along the side where you see this blue tarp, this is actually an aisle, an area that extends back with several homeless encampments. Tent cities, as we're calling them now, because that's what they are. They're actually cities within the city. So much so that they've actually started to develop their own subgroups or their own subcultures within the tent cities. And so there are some cities where there's a high crack prevalence. There are some cities where there's tent cities, where there are more IDUs. There are some where there are more sex workers. Not as many where there are sex workers, but they are there. And meth has actually made a huge upsurgence in the Oakland area, and ultimately that is one of the drugs that they use more frequently. Let me see. There we go. The encampments If you've driven around Oakland, you've seen them almost everywhere. They are almost everywhere. These are people who have been in the community for almost their entire lives. When you talk to a lot of the people, you'll find out that some of them lost their business and they were struggling to hold on and ultimately ended up in the tent. Entrepreneurs. Some of them lost their homes. A few of them, there's substance use. There's a lot of mental health issues with this particular population as well. So you have these co-occurring diagnoses that you end up having to deal with. Now, in doing this testing, we've identified a number of new positives, but we've identified an even larger number of out-of-care positives. People who have basically abandoned the medication adherence piece because they had to focus on their daily needs, the essentials that they have to have on a regular basis. Now, in these communities, we've watched the smaller clinics get consumed by these larger hospitals. And so they'll shut down that neighborhood clinic. People won't go to those anymore. Their doctor isn't there anymore. They have to go to this large hospital. We've actually seen instances where medication adherence tends to be really difficult because meds will get lost in transiency. They're going from this site to that site. A lot of tents will end up burning up because people are just trying to stay warm. We'll run into situations where they have to choose between selling their meds and taking their meds because they have to eat to take the meds, and if they don't have no money to take the meds, and they're going to have to get something to eat, so they'll sell off a few. And then the twos and fews become their whole prescription, and they got to go back and say, somebody took it. You know, we have a medical transport service where we transport positives to and from their appointments to help them along their treatment continuum. When we go to pick up our clients, many times we run into situations where they don't want to leave their encampments. They don't want to leave their encampments, not because they don't want to make their appointment, because they're afraid all of their stuff will be gone when they come back. These are some of the things that we're noticing, that we're experiencing. And with our clients, with our community, because gentrification is real in Oakland. I don't have all the answers. I can't tell you what we're going to do about all of this. What I can say is we need to do something. I love the fact that we were able to have Dignity House put up the little structures, the little small tiny homes, and help people to try and get into SROs and other communities, but it's still not quite enough. We have encampments right next to shopping malls, shopping centers. Many of these pictures I took from far away to protect the privacy of the clients. This is why some of these pictures are so far away, but nonetheless, that whole row along that little wall right there, all 10 encampments right behind Emeraldville Shopping. It's real. When we go out there to meet the needs of the people where they are. Their time, their turf. Till 2 in the morning, from 6 a.m. to 2 a.m., we are out there. We've learned that it's not just being out there with these unconventional hours. It's being in the places where everybody else doesn't want to go. It's not a 9-to-5er kind of job because people's lives aren't just 9 to 5. Another situation, nice condos right next to a large homeless encampment. This has become common here in the Bay Area. This is not just a big city thing. We used to be able to say it was New York and San Francisco. Oh, this is bigger than New York and San Francisco now. This is real and it's here. So when we talk about addressing the needs of our community, we have to be mindful that if we don't do something about their other needs, we'll never be able to get them to see their health seriously enough. It won't be a priority. I know that it may appear that I've bounced around a little bit, but there's so much to say, and there's so much to talk about, but I just wanted to put a few things on your mind. Think about what you can do when you leave here, when you're addressing your supervisors, when you're addressing your funders, when you're addressing your congressman. What can you do to improve this situation that we're facing in Oakland? Thank you.
Hello. Hi. So I don't have any slides, so I'm just going to, you're just gonna have to look at me, okay? So let's talk a little bit about circular migration. So gentrification, I think this was like a nice segue, right? Gentrification began for Native Americans back in 1492, and you know, we've been struggling ever since. But let's talk about circular migration specifically in the Bay Area, which I think is very important, especially with Two-Spirit people. So in order to sort of understand how circular migration is working for Native Americans, we sort of also have to look at it from a historical perspective. You see, San Francisco and the Bay Area has always been a very important part of that migration, because there is something way back when. Dylan Myers, he was head of the BIA, and he created this thing called the Indian Relocation Act. And what it did was it took people who were in rural areas and brought them into urban areas. And that's really where the circular migration really started for lots of Native people, because all of a sudden in the 1950s and throughout the 60s, there was this constant flow. People would come to the cities, and then they would go back to the reservations or the allocated lands, or what we call in the Native tradition as tradition. It's a pan thing. As Indian country. So anytime you're dealing with something that we're referring to as Native American, we often refer to it as Indian country. So in Indian country, we did this continually. We were going back and forth and back and forth and back and forth. And a lot of that had to do with just the opportunity that you have in an urban city. So I want to talk a little bit about like one of the reasons why people actually do this circular migration. Well, I think it's very important to say that before we start anything else in the Native community, we start with our spirituality, right? So we start almost everything that we do. If you've ever been to a Native event, they always start with a prayer. Doesn't matter if people in the audience are atheists or very devout in their religions or whatever, we always start with a prayer. And unlike some religions, we're not proselytes, so we're not out there trying to get you to come into our religion. We just let you come in for the moment, and then when you leave, that's fine too. Bye, good journey. Walk in beauty. It's true. And so we have this spiritual contingent that's very important to us. And also because we often come from very rural areas, we're extremely close to our families. So what happens is you go to a city and then you're coming upon the solstice and you're like, oh, I have to go back, I have to go for ceremony. And you know, in a lot of the Western culture, you know, your big holidays is like, you know, Thanksgiving or Christmas, and oftentimes you go and you have like a big meal and you're done, right? Native tradition usually starts with like about 4 days. So that means like sunrise ceremonies, sunsets, dancing, food. It encompasses a lot of stuff. So a lot of times you go to the big city, then ceremony happens, and you can't really keep your job anymore because, you know, a lot of people are like, what? You leave 4 times a year to go back and then you're gone for like weeks. So it's not a great thing of keeping it. And then to layer on top of it, if you're a two-spirit person, there's a whole different level of things. So let's talk about that for just a moment. So why do two-spirit people come to San Francisco? Is it just because it's a big gay area? Well, partly, but also there's another big part. And I didn't bother you with the big slides and everything about statistics, but actually, in a recent study they did in New York City of people who originally come from reservation lands and allocated lands, they found that like almost 46% of two-spirit people had experienced violence back at their home due to being two-spirit. So, you know, there's a misconception, I think, that because we had historically had people who we call two-spirit LGBT people in our tribes, that we still have them today as like these sacred and protected people. But that's not really the case. We're very acculturated, and many tribes are very Christianized, and they don't see the sacredness or the holiness of these places anymore. And so you find this violence that is happening in these areas. So there's that, and then there's layered on top of it is opportunity. So in most cities, in most urban cities, you start a business, right? So you go through, you know, your city and your state and everything else. Now imagine being on a reservation, which has more red tape, because you have to go through your tribe. And oftentimes you have to go through your tribe and then go through a city and then go through a state. And sometimes what you have to do in some tribal nations is you have to have approval by a board, and then there's zoning. There's a whole different zoning category among Native tribes. So a lot of times it's hard to start a business if you're Native on a reservation. So if you're not Native, then it's easy for you to start a business, but then the problem is that then the tribe has problems because they can't enforce laws, especially their tribal laws, because of sovereignty rights and everything else. So it gets really, really complicated really quick. So in other words, what happens is if you violate the law on a reservation, you can't really get prosecuted by the tribe, and then you have to go through the state, and the state may or may not want to even take on that risk. So again, opportunities layered up on this. And then for those people who are still sort of like closeted because they don't really like the violence for some reason. So they're closeted, they're married, then they come to the city, and then they have sex with men, and then they come back, and HIV continues to be transmitted because we're not quite hitting it. And then here's another thing too that's completely fascinating. So in most of Indian country, there's something called the IHS, the Indian Health Service. So it's a great thing, but in most Native areas, you have 3 opportunities of employment, really. You have working for the tribe, and that means the tribal complex of some sort. Working for casinos, which is another big employer, or you work at the IHS system, or somewhere in one of the clinics. So this is where it gets fascinating. So, you know, I'm related to the Browns and the Shields and the Thomases and the Gars and the Brashikas and all these relations that I have. So if I go to a clinic for something, then who do you think is going to be working behind the desk? It's going to be one of my aunties, right? So they're going to know exactly all about my business. And then they're going to tell everybody else. So knowing this, a lot of Native people decide, I'm not gonna go to the clinic at all. I'm going to move to this urban area, and then I'm gonna go to the clinic. And they do that, but then they move to the urban area, and then they find themselves a little bit isolated because, like I said, what do we start with? We start with our spirituality. So we're missing our spirituality. So we don't want to go to the doctor just to cure what's ailing us physically. We also want to be cured spiritually as well. So for Native people, we want more than just what's wrong with us. We want to be taken care of completely, a holistic approach, because that is natural for us. And connecting with somebody very humanistic is very important for us too, because when it comes to all the papers and the statistics and all that, it is just completely crazy for Native people because we want to connect with people. When we go in, we expect our caretakers to be our friends, because that's what we've always known, is they're our family, they're our friends, and so we expect the same thing. So when you're dealing with Native people with their circular migration, you have to remember that you can't just approach them just as you do everybody else, because they're expecting more, or rather they're wanting more, and they don't always find it. And what was so important for this organization that used to exist here, called the Native American AIDS Project, which really addressed those specific things. So right now, a lot of times you find like the Native American Health Service in San Francisco and Oakland, and you see a lot of people going there, and they don't just do the doctoring, the medical, physical stuff, but they also have drum classes and all these other things, because really when Native people go there, they want to feel like they're a part of that community. And so I'm going to end with that, but you know, because I'm Native, I do want to end with sort of a little bit of spirituality. Are you guys down with that? Okay. We have this saying, when we say thank you, we don't actually say thank you. What we say is like, it's all good, or it's as it should be. So I want you to say it with me, and we say, yak okay. Can you say that? So we're gonna say it 3 times, okay? So, yak okay. Yak okay. Yak okay. Thank you.
Hi. My name is Miguel Ibarra. I'm from the San Francisco Community Health Center, formerly API Wellness, as of a couple weeks ago. So let's see. First, I want to say that I'm aware that I am one of the people standing in between you and your lunch, so I will go fast. And second, I'm really appreciative of the last presentations that just went up, especially the one that just went up. So thank you. And then also thank you for having me. So today I wanted to talk about homelessness, or as I like to call it, houselessness in San Francisco. I didn't bring any like numbers and things like that because I think we all recognize that it's a problem, and we all know that. So what I wanted to sort of show was photos of homelessness in San Francisco. But what I wanted to highlight was the fact that these are photos from national newspapers. So nationally, it has been recognized that homelessness in San Francisco and the Bay Area is an issue, but what we're not doing is necessarily responding to it. And so what we have done so far is actually have responded in alternative ways, like recognizing, okay, we need to do something, but like systems don't really let us, so we should try to do something ourselves. And so again, this is mainly where we work, and these are our folks. So Civic Center, right in the heart of San Francisco, 2 blocks from our office. Our clients are everywhere. We can't go anywhere without them finding us, which is actually really great and also kind of a bad thing. But what I wanted to also mention is, you know, the importance of like folks that fall out of care and the importance of retention and reconnection work, which is beautiful considering the amount of navigators, case managers that are just hitting the street and that I recognize and get to know on a daily basis. Like, I just love it so much. So in San Francisco, youth, gay, bisexual, men of color, transgender women, and injection drug users are at the highest risk of falling out of care. But what exactly are we doing? And why is retention work so important? So yeah, in San Francisco, 28% are not virally suppressed, and nationally it has kind of been said that 9 out of 10 new HIV transmissions are linked to people that are not in care, and yet we're still trying to get to 0. So HOME, first I wanted to talk about like sort of like system challenges and successes for us in the HOME program, and then talk about the program itself. So in terms of system challenges, you know, there's not enough housing, and it's stabilization and supportive housing. Most of our folks, you know, are homeless, dually diagnosed, haven't been in care in years, are really, really traumatized by the healthcare system, you know, are not comfortable seeing a provider. And so, yeah, they need stabilization rooms and they need supportive housing. They need case management, they need nursing. And there's not enough of it. And unfortunately, there's more, the homeless count is actually growing and the amount of units is decreasing because, you know, San Francisco does a wonderful thing of saying, you know, we're gonna build low-income units, but it's gonna take us like 10 years to do it. So there's that. And then there's lack of trauma-informed care. And then there's communication between hospitals and hospital communities or your community clinics. So that's another issue. We're working with clients that are high utilizers and, you know, who are in some ways costing the state a lot of money, but the hospitals don't really do anything about it. You know, we ask them, you know, call us and let us know, you know, if our clients show up or if the patient shows up, and nothing really happens. We put alerts everywhere, but then nothing happens. And what we're trying to do is we're trying to like create presence in the hospitals and tell the hospital, you know what, like, we got this. Like sometimes like our folks just come in because they're on the street, they're scared, they're traumatized, they feel really sick. A lot of them, again, suffer from paranoia, anxiety, and a lot of that brings them in because they don't know what's going on. But oftentimes, like they come in, you know, they're acting very psychotic. The doctor reads, oh, meth, and then they just send them on their way. And so what we're trying to do with the hospitals is trying to teach them, like, if you just call us and let us know that they're there, and if you give us enough time to get there, like we would not only be saving you time, but we'd also be saving you money. And then there's not enough case management programs or step-down programs. And then this is especially related to palliative care, so HOME. Well, we try to work with our individuals on the street, really anywhere, who have decided that they don't want to take medication. And if that's the case, then we're going to be holistic. We're going to be kind. We're just going to be supportive. We're just going to show up and hold space. And, you know, if you decide to, then great. And if you don't, then we're just going to support you and, you know, for as long as we can. And then, of course, like political environment is constantly changing. And so far, you know, I think when the HOME program started, it was 5 years ago. So that was, you know, His Royal Highness Obama. And currently we have number 45, and he hasn't returned any of my phone calls. So, yeah. But what works? So yes, trauma-informed care works, informing providers that their patients are traumatized, sometimes by them. That works. Flexible treatment plans, and I mean treatment plans that are actually driven by the client. Those are the things that works. Cross-training and having integrated teams, so team-based navigation, those things work. Constant communication amongst teams, amongst the teams, different organizations. I have said this before when I've come to the East Bay for different groups. I've said, you know, my dream would be that I like hop on the BART with my client, and when I get to Oakland, that like the navigator from Oakland is there. And like that's the warm handoff. That is my dream. So when that happens, I'll be the first one. So yeah, starting treatment anywhere and any time. Dr. Bourne, who's the medical director on our team, she says the treatment plan is anything. It can be medication, it can be hugs. Whatever the client wants is what the client's gonna get. So yeah, team communication, community pharmacy, like you're gonna get meds wherever you can get them. Support from our lead agencies, and then of course, courage of consumer and teams. So we're just trying to build confidence here. Partnerships are very important, and those are things in like our 6 years we've been able to do. So working with safety net clinics, medical and psychiatric emergency rooms. So again, sort of like recognizing that clients are going through a lot and really they just need some support when they come in, and so calling us and letting us know. We've gotten like 10% with San Francisco General. My goal is to get to 20. working with jail health, working with the surveillance teams, surveillance has access to so much information, and oftentimes they just keep that for themselves. And so I would love more. We work with pregnant women, and so working with Hive at General, and really identifying women that are gonna need just a little bit more support during their time, especially when they wanna have the baby. And then supporting them so that they can keep their babies. And then working with Project Open Hand, so recognizing too the importance of maybe like a Meals for Meds kind of program. So if we're working with folks that are on the street and don't really have a lot, then maybe, when we come by and bring them medication and we do our counseling, we also bring them a hot meal. And so looking at our different partners, I think one thing that has worked for us is sort of like recognizing, that, we're not just a team, we're actually our job is to hold the different agencies that support all of our clients accountable, and, bringing them to the table and finding a way to include everyone's voice and sort of saying like what's gonna be the appropriate level of care. So we work with the hospital, we work with the transitions team, which supports homeless folks and moving inside. We work with the homeless outreach team. We work with prevention. We work with the jails, primary care clinics, and then the housing department. Some unexpected successes. So yeah, there's been a lot of system-wide coordination that's been really great. And then working more towards palliative care and advanced care planning, working with our homeless folks especially, and sort of saying, you're out here and well, this is also different. So in San Francisco, we've had a lot of folks that, call themselves professional homeless people, and it's mainly because they've been homeless for 25 plus years because they want to. And so, what we do is sort of say like, we want to recognize that this is what you want to do, and at the same time also say that, should the day come, we want to make sure that you're taken care of and that you're ready and that you're, should you not be able to make your own decisions, that we're gonna find someone that can. And then also too, and this is really a wonderful thing, is we're a direct service program that in some ways like shadows as a capacity building team. And so we've been training medical students, residents, and fellows, and really we just recognize that you can't get to zero unless providers leave the clinics and hit the streets, because that's where their patients are. And as someone said, people don't wanna leave their home to come to the clinic for the fear that, when they get back, it won't be there. So program design, I just wanted to sort of show where home sits in the spectrum of services. So we are a level 3 program. Usually it's when our clients have been kicked out of the zeros, the ones, the twos, and no one wants to work with them, we show up, and those are, in my case, like the perfect client. We're targeting the hardest to serve. And I only say that because they're not really that hard to serve. Again, if providers would just leave their offices and hit the streets, you'd find that your patients are really willing and agreeable and open to taking their medication. It's just that a lot of stuff happens in the time that it takes from them leaving their tent to showing up to clinic. We work with people, people who haven't been in care for a very long time, people who are actively using, diagnosed, dually diagnosed, experiencing homelessness. We also work with pregnant women and their partners. We work with transitional age youth, which is heartbreaking in the city of San Francisco, because oftentimes kids in the Larkin program are going through a lot, and they're going through a lot at 25, and they find themselves with nothing after they leave the program. And so we try to support them, show them that there is some hope for them, and then hopefully get them housed. People who are newly diagnosed, or people who are at risk of eviction. We do a lot of eviction prevention, mainly because we're recognizing that once they're out, the programs aren't that helpful, to get them back in. In terms of a recipe, so we see our clients about 2 to 3 times per week. We do regular mental health and substance use assessments. We provide them a lot of emotional support through navigation and case management. Our partnership with the homeless outreach team provides us with benefits and eligibility access, and then also at some point housing, and then just having presence in the community with outreach. We work through to sort of identify levels of care, so identifying what's going to be the appropriate amount of intensity of service for a client, and that's really just looking at somebody's ability to engage medically, take some meds, navigate systems on their own, how well can they case manage themselves, how much, is their substance use actually a barrier? And then their mental health. In terms of, I really wanted to sort of focus on this one in particular. So 72% of all of our clients have reported experiencing some sexual or physical trauma. And so really, again, just holding space for that and allowing them to address and process on their own. It just recently ended, but HOME was a SPINS project. And so there is some data here. But what I wanted to show is that, going outside and providing services is actually really great. And it actually works, because 66% of our clients were actually able to reach viral suppression. And I know that that's kind of like the one way that you show that you've actually been working. We've been able to house a lot of them and actually keep them housed, and have been able to graduate most of our folks. Let's see, so we've been able to successfully discharge and transition 70% of our folks. 30% of them is just sort of acknowledging that they're gonna need that level of care for their whole lives, and just creating space for them. So looking forward, systems fail, not the clients. And if the client is failing, it's because we're not doing the work. And then the client success comes from their own resiliency, coupled with pooling resources, integrating care between agencies, and clearly defining and addressing system gaps. So thank you.
I'm going to invite the panel up we'll have about 10 minutes worth of questions from the crowd. So if the panelists can come up, we're going to leave the tables over here so that folks aren't having that light beaming right in their faces. Sorry about that, Miko. So if I can get all 4 panelists to come up and sit, and we're going to open this up for questions. I don't know about you, but I was on a roller coaster listening to this presentation, because I was going from being really pissed off, because we have shanty towns basically in our area that we as a society have allowed to exist and grow, but also being very heartened by the incredible work that folks are doing for this population. Okay, so any questions for our panelists? And I got them all back up here, so you guys have to ask. I know that it's going to be lunch, but you have to ask them something. Well, I'll start it off. I'll ask a question. So given what you all have talked about, and you started giving us some real solutions, Miguel, but like what are some of the things that you think are the most impactful that we can do, given all the different populations that you're working with? What are 1 or 2 main kind of take-home messages that you would give in terms of really successful strategies?
The first I would say is just communication amongst your community partners. I found that in the work, what's really important is making sure that, as a navigator, case manager, even doing program management, it's that the different providers are aware of our folks, and that also at the same time that we're aware of all the work that we're doing. One thing is that our clients tend to sort of navigate really well for resources, free resources, and so they hit different providers for different things. And it's sort of acknowledging to if my goal is working on med adherence, then I want to make sure where are they going for food, where are they going for clothes, where are they going to church, because then I know who I have to call when I can't find my person, especially when I have to give them their next bubble pack. And then the other thing I would say is just good old-fashioned, just show up and be present and know that not everything's going to happen on the first try. And sometimes, as long as they don't say no, it means that they still want you to be there.
Thank you. Anyone else?
I just want to add that what we do is we also have one point of contact for all services, so the clients are calling different places around the county. There is actually one phone number that can access all of our services directly, and then we actually have live people they can talk to. So we have a medical social worker of the day that's in the office that answers questions. When clients come in about, even if they're not that client's medical social worker, they can actually start helping the client right then and there about whatever issue they're calling about, as well as our test counselors.
I would definitely say, because we encounter many of our clients at times where traditional brick and mortar agencies aren't open, then finding creative ways to increase availability of services is really key, because when if we're out there at 1:30 in the morning and this client is saying, you know what, I'm tired of this, I need something right now, and we say, okay, well, tomorrow morning I'll get you in something, that doesn't quite work. And so I would say definitely one of the biggest things we would want to consider is how we can creatively come up with effective ways to create warm handoff situations. It's great that we have that in Contra Costa. It's great that we have a couple of partner agencies here who are trying to work with us, but it's still not quite enough. When we look at the needs of our clients and the fact that they don't have the traditional, 9-to-5 type needs, then we need to make sure that our services reflect the needs of the community that we're trying to serve.
Great. Any other questions? Oh, okay, we have a few. Oh, yeah, go ahead. Is it on? I don't think it's on. It's not on.
Hi. So I know gentrification is part of this bigger Bay Area movement towards like urban renewal, but obviously like one of the most insidious effects is the ways that it tears the social fabric and the social networks of a lot of marginalized communities. And this question's for Miko. So you mentioned like there are these Native American health centers where many people can work in, but if anything, for a lot of Two-Spirit people, they would feel judged to see their aunt or uncle providing the services, or at least somehow knowing through the social network like what's going on. But at the same time, they don't feel completely included or supported in urban settings. So I'm just curious if there are any interventions, or if there are any, is there a lot of work amongst the Two-Spirit community to change that kind of culture within their own social network community amongst Indigenous people?
We actually have a lot of great things started going on in the Two-Spirit community. One of the things that we do each and every year is we have this annual powwow, which is actually really large. I believe last year we had around 6,000 people coming in. And it's not just for Two-Spirit people, but rather for our whole community. It's just put on by Two-Spirit people. But one of the things it does is it brings in a lot of people, especially those people who are seeking out some of their ceremonies or spirituality and stuff, and it brings them in. And it connects them with all these different organizations that we have there. In San Francisco at the Native American Health Center, there's something called the Two-Spirit Talking Circle. And this is something that sort of brings them in. And one of the great things about the Native American Health Center is that a lot of times when people are coming from like all over the United States here to San Francisco, is you're not intimately connected with them, and you're not the same tribe, which is a big thing. So they don't worry about being reported upon when they're outside of their own area, because there's less connection. But that talking circle is really important because it brings them actually inside the Native American Health Center. So when you're going there, all of a sudden you see all the services that are available to you. So we're providing not only a spiritual place for them, but we're also talking about talking circles, which for many Native Americans is just a part of our traditional life. We have talking circles a lot. It's not processing circles, it's talking circles, which is very, very different. And in that way, we really connect with them on a different level, because it's something that they're used to, it's something they're familiar with, and it feels more like family.
Thank you.
Hi, I just wanted to ask in terms of social justice policy advocacy, what would you have us do or say? Because right now we're at the tip of another iceberg of racial justice conversations. And I think, one of the things that the panels have brought out for me this morning that I have suspected all along is that, first of all, racial justice is not just a white-black issue. So how can we better serve you know, talking about the policy issues of discrimination and just plain being left out of these conversations in other areas in terms of funding, in terms of visibility, and what is like meaningful involvement of people from other racial groups besides getting a seat at the table. Because I think, you know, we know just from being black, having a seat does not mean that you have power and influence in and of itself. So what would you suggest that advocates do so that we're really inclusive of, you know, all the races and nationalities in the HIV community? Because it is a sad thing to know that we still have this kind of structural racism within even our community that's inclusive of other people and makes them feel meaningfully involved.
Thanks, Lauren. Does anyone want to take that one on?
I don't know if I'm gonna take on the entire question because that was wow, thank you. I will address part of that though. Yeah, you're right. It's definitely not a black or white thing anymore. You know, because not only do we have to deal with racism, we have to deal with classism. What's really interesting is even in the communities that we're serving right now, even within the tent cities themselves, you have people who don't want to associate with people from another tent city, which is just like right down the street. I tell my sons this all the time. Willie Lynch is real, you know what I'm saying? That whole that whole thing from that whole Jim Crow era where you know, you pit the lights against the darks and the talls against the shorts and the rich against the poor. You know, that is so deeply ingrained in what we have here in America that we tend to project that. We take it on and project it on whoever is whoever we see as a viable victim. You know, I would say as far as developing policy and stuff to address some of those issues around racism, classism, and things of this nature as it relates to disparities here in health with gentrification, I would say that we would probably have to look at starting smaller, starting from within the agencies themselves, establish a norm that will transcend all of the other BS, if you will, that they're experiencing out in society, so that when people come in, they can actually come into our organizations and feel as if they can let all that other stuff go and just address the needs that they have at that time. Many times it really is about what I need right now. And if we're open to addressing their immediate needs, then they may be open to letting us help them to address some of their more long-term needs.
Thanks, Roger. I think there was another couple questions in the very back, towards the back.
Well, yes, I realize all of you may not be on the front line, but I know Roger is, seems like Miko is, and Miguel, are you?
Every day, even Saturday.
And my staff
Every
of
day
10
you decided.
are.
So, and you are too. Okay, so thank you. Thank you for doing the work that you're doing and being out there in the communities, because that seems to be disappearing. And it seems like that's where the need really is, to get out there and be amongst the people, to help the people. So I guess my question is around the trauma, in terms of how do you deal with the trauma? Because gentrification is traumatic, as far as I'm concerned. When you live in a community and you see it changing before your very eyes, and you too think, wow, who knows how long I'll be in this community myself. But you're there with the homeless in the 10 cities and folks that are migrating back and forth and feeling like Maybe they just don't have a grounding. So how do you deal with the trauma, to help folks? The migration can be a trauma. And of course, the gentrification, as I already said. So how do you deal with the trauma? Because, I know there's this these trauma-informed approaches that we should be thinking of. But rather than it be just a concept in the ethos, how are you, applying it practically for the people that you serve? And how do you keep yourself from being traumatized doing this work as well?
Great question. Thank you.
I think it's
So what does trauma-informed care look like? Sorry.
I think it's interesting that you brought that up because desensitization is something that is actually real among people who work in, these sort of situations in these communities. We just had a staff meeting the other day where we were talking about how we've began to accept as a norm the large rats that run in and out of the community, in and out of tents. But it's because many of our clients have accepted that as a part of their reality. One of the clients the other night said, the rats were here and we moved into their neighborhood. So, we just, they don't bother us, we don't bother them. And it's with the trauma that we initially experienced, that shock of going out there and, oh my God, I can't believe this is real. What are we supposed to do? This is like one of those, crazy movies. We actually have to talk among ourselves a lot and decompress every night that we go out there. And we have to talk through stuff every night. And the stuff that we see when we're out there in the community in the wee hours of the morning will blow your mind. I don't want to take up a whole lot of time talking about this, but this is, if you could just imagine, there are people who actually have smoked off their fingertips, burned them off with the pipes, trying to self-medicate so that they can forget about what their current situation is. And they come to you and say, I need help. What can you do for me? I've already been diagnosed bipolar and schizophrenic. And I've already, I know I got my substance issue and I'm homeless and, and my partner is already positive. What can you do for me? You hear that enough times and it starts to weigh heavily on you and you have to make a decision. Okay, am I gonna let this break me down or am I just gonna have to, exercise my boundaries and say, I'm not gonna let it bother me for a minute. But it has to bother you at your core at some point. And so for us, it's talking through it. For us, it's recognizing the human component of what we do and not criminalizing being homeless, because being homeless isn't a crime. That's it. I can go on for a minute, so I'm sorry.
I have, in terms of your question, I would say, like, for direct practice, I would say starting off with what your client's goals are, because you know yours, right? And like in my case, like I know what the doctor's goals are, like get them on meds now. But I know that the client's not gonna do it unless I kind of address their needs first. And so, write them down and say, all right, what's your top 3? You're not gonna get housed today. So like, what's your next one? And then sort of just work from there. And I would say one thing too that I recognize is less boundaries are actually better, as long as you're staying true to yourself and you're protecting yourself. But then with that being said, it's very easy to become over-involved in your client's life. And what I always try to remind myself and what I try to remind other people is that it's already, like, the client's already facing stigma, and it's stigmatizing to have an adult show up in an adult's life and tell them, like, you're not adulting correctly. So they're already going through so much, and you showing up is just a reminder of all of that. So it's like, don't put up boundaries, don't get over involved. And then I would just say, just continue being present, and holding space is a beautiful thing because it gives the person time to reflect, but it also gives you time to reflect on how you're supporting someone.
Does anyone else want to address that?
Just one of the strategies I use is, I have a team of test counselors that go out to the community in the mobile testing unit. And what I do, so they're trained to be client-centered to our clients that are testing and they're educating, but I'm trained to be client-centered for them. So when they come in, I talk about how was your day? How was the testing event? What happened out there? And a lot of times there are, very difficult situations, and they feel that what they're offering is not enough. But I try to remind them that the service that we are offering is also important, and the fact that they're there, they're doing that work every day is also very important. So I really validate them in their work.
Thank you. Please join me in thanking the panel. Okay, we're going to break for lunch. You all probably saw those lunch boxes out there. I'm going to ask you all to do something very, very difficult. And that is when you hear that bell at one